Hi, I thought I'd give members a bit of an update on where we see the NHS in England going over the next few years. Not a particularly easy thing to do because I think it's fair to say it's still work in progress. But I think there are three key issues that we need to be paying attention to. The Health and Social Care Bill has become an act, and that dramatically changes the way that the health services in England are provided. At the same time, we've got real economic pressures, and we're going to experience real challenges in terms of having enough resources to meet demands. The third thing, which I think is important, is that trusts are providers of NHS services are going to find themselves monitored very closely, both in terms of financial performance but also in terms of quality. And the Care Quality Commission is going to be playing an increasingly important role in determining whether or not providers are fit to deliver services. Alongside the Care Quality Commission, Monitor is going to be increasingly focusing on financial performance. And we already know from recent events that a large NHS trust in the south of England is being, if you like, taken into administration because of its financial performance. And that's the first time that we've seen this happening. It's not about quality, it's about finance. On the other hand, we've also got situations across the country where providers are increasingly being determined as failing on quality. So a lot of challenges ahead. So what's going on out there since the passing of the bill? A lot is the answer. The National Commissioning Board is going to be the key organisation in terms of centralised control of the NHS. But of course, what we're seeing is increasingly control devolve to a local level. And whilst the National Commissioning Board is developing, we're also seeing the clinical commissioning groups developing. And what I can tell you is that there's a huge amount of work going on to ensure that there's a good framework for commissioning, to ensure that the clinical commissioning groups know what they're commissioning for. In other words, outcomes are being developed against which the people who commission services will assess the performance of the providers. Another issue that's being discussed is how will advice flow into the National Commissioning Board and indeed from the clinical commissioning groups. And we've got thoughts developing around clinical senates and around how the Royal Colleges will advise into the system to make sure that at every level decisions about NHS provision are based on professional knowledge. So all of that's going on at the moment, and there's still a lot to be determined. At the same time, we've got the development of the health and well-being boards, which at a relatively local level will look at the provision of both public health and more acute health services and try and ensure that what is being commissioned locally meets the needs of local populations. And these health and well-being boards and their plans for the future health of local populations are going to be incredibly important. As I say, the health and well-being boards links the sort of public health side of the NHS with the more acute side of the NHS. And there's a real determination to up the ante in terms of health prevention and trying to take some control over the nation's ill health by stopping them getting ill, so to speak. And a very significant issue is that in terms of public health, we're going to see much more joined up working between local government and health services. So a huge amount going on in that area as well. So what does all this mean for midwives and maternity services? Well, I suppose the first thing is that midwives have really got to get in there, find out what's going on locally, and particularly those who are in leadership positions need to ensure that they're talking to people about what high quality maternity services look like. And I would very strongly suggest that now's the time to feel that we can be influential and can, if you like, furnish the commissioners of services with ideas as to what works best for the local population. What does good look like? And in these difficult economic times, how can we deliver high quality care at a reasonable cost? And it's very important midwives grab the chance to argue for what we know is best. And I think it's a very good time to argue for midwifery-led care for all women, but particularly for low-risk women. This is a time we should be arguing about the importance of midwifery-led units, home birth services, as well as very high-quality obstetric services. But it does mean a lot more for maternity services. I think we're going to see much more enthusiasm than we have in the past for alternative service models and indeed for alternative service providers. We already know that there's a very successful midwifery practice developing in the Wirral called one-to-one, and that is based on a business model. One-to-one is being commissioned by the local commissioners to deliver maternity care to high and low risk women who are socially deprived. And they are at the moment looking extremely successful, and this is a very different service model. These midwives are not employed within the NHS, they're employed within the business, one-to-one, and I think we all need to look at this model and consider whether or not we can provide similar models within the NHS, or whether or not there are going to be more of such businesses developing. We've also got neighbourhood midwives, which is a different model. It's a social enterprise model, and that's proposing to deliver services under the NHS banner, i.e. commissioned under the NHS, but by midwives who are part of a social enterprise, not by midwives who are employed by the NHS. It's very important that these new service models are part of a maternity pathway, and the other thing that we're waiting to hear about is whether there will be maternity networks set up centrally by the National Commissioning Board, or whether these will evolve locally. It's my view, and I think it's a view held by the government, that in a situation where there's much more local commissioning of services, it's going to be very important that we also work together within networks in order to ensure integration, collaboration and coordination of care, which is possibly provided by a series of rather different providers than in the past. I hope that makes sense, but we really do have to look at that. Finally, I think the other thing that we really need to get hold of as midwives is our role in public health. And when I say get hold of it, what I mean is that we must tell people what it is that midwives do in this area, because there's going to be a lot of focus on this. I've mentioned the focus on preventing ill health, and I think midwives have a huge role to play in that. Every woman accesses a midwife, and this is often the first opportunity for women to get really important messages around smoking, around obesity, around breastfeeding, very important public health issues. So we must get out there and explain what midwives can do. So a very different world emerging in the NHS in England, and it's going to be both different because there's a different focus with much more locally based service provision. It's also going to be different because the resources are tight. And perhaps in relation to that, the final thing I think we should be aware of and watching for is that I think the reconfiguration debate is going to escalate. I think increasingly we're going to see services consolidated with the more specialist type of services provided from larger units, and then the more universal services increasingly provided out in the community. So what does that mean for maternity? It probably means that we will see some of our obstetric services consolidated into larger units, but hopefully at the same time we'll see an increasing number of locally based midwifery units where we can provide antenatal, labour and sometimes postnatal care. And I think it's very, very important that midwives participate in that debate and challenge the concept that any closure of a local, relatively small obstetric unit is a downgrading of services. We also have to make sure that where services are consolidated, as much of that service as possible is provided locally so that women don't have huge travelling times. I could probably talk to you in a few months' time and everything would be further along the road and developing, more than I've explained at the moment. But I think that will have to suffice for now, and hopefully we'll get a chance to update this issue shortly.